Next talk is on surgeon's role in management of rectal cancer. What is new? And Professor Surendra Kumar Mantoo is going to elaborate on this topic. And Professor Surendra Kumar is the consultant surgeon, Department of General Surgery, University of Texas, USA. Over to you, Surendra.
Dear friends and colleagues, I am Surendra and I thank the organizing committee and Professor Nisanka for inviting me to give a lecture on surgeon's role in management of low rectal cancer, what is new. These are my credentials and I have no disclosures to make. I bring you all greetings from the island country of Singapore, and this is the place I work at. It's a very green and relaxing place. Rectal cancer is common, and over the last few decades, the incidence is increasing, especially in the younger patients. There have been some remarkable improvements in management of rectal cancer, and it is curable and mainly by surgery. But we all know that rectal cancer surgery can be technically challenging. If we look at the evolution of management of low rectal cancer, there have been some significant developments in the surgical management, especially in the surgical technique, neoadjuvant and adjuvant treatment strategies, as well as the perioperative care over the last 40 to 50 years. When we talk about surgical management of rectal cancer, over the last decades, there has been a drive towards lesser than radical surgery, and there are many reasons for that. Patients want a better quality of life without stomas. They want improved outcomes in terms of sexual, urinary, and bowel dysfunction. And as surgeons, we also want lower morbidity and mortality for our patients. The other main reason for exploring different surgical options is that rectal cancer can present in different ways. It can present as an early rectal cancer, where some of us may feel that a radical resection is an overkill. It can present as a locally advanced cancer, which is very much suitable for a radical rectal resection, or it may even present with lateral disease, where a radical rectal resection may not be sufficient. So currently, a surgeon, I would say, is at crossroads when it comes to management of low rectal cancer. We have a well-established path of radical rectal resection, but new pathways of local surgery, extended surgery, and even no surgery are being explored. Whatever the path we take, as surgeons, our main aim should be to offer a high-quality surgery with the best possible outcomes within our available resources and training. In this talk, I'll be discussing these options and share my insights on these different approaches for managing rectal cancer. To begin with, radical rectal resection has been the most well-explored path, and in my opinion, there have been two landmark developments in terms of surgical technique of radical rectal resection. The first one, as we all know, is the total mesorectal excision, popularized by Professor Bill Heald, and the second one is extralevator abdominoperineal excision, with the first report being described by Holm and his group. Both these techniques have significantly reduced the local failure rates in rectal cancer and have improved patient outcomes both in terms of morbidity and mortality. But things never stay simple. As surgeons, there is always a desire to improve on the things we do. The technical debate on how radical resection should be done is still open, and the main contenders are the open, the laparoscopic, the robotic, and more recently the transanal TME approach. These techniques have been compared in multiple scientific studies in terms of clinical outcomes, oncological outcomes, cost, and more recently, the functional outcomes. These are some of the landmark studies when we compare the open and laparoscopic approaches for radical rectal resection, and the current consensus is that laparoscopic approach offers improved early clinical outcomes and possibly has no oncological inferiority when compared to the open approach, except with the exception of maybe one or two studies as shown here. On comparison of laparoscopic and robotic approaches, there are few studies, and currently we can say that robotic approach has similar benefits of MIS. There may be a lower conversion to open approach. Possibly there are no oncological differences, but there is a higher cost involved with this technique, and with better visualization of the nerves. Some authors have reported that there may be better functional outcomes with robotic approaches when we compare it with the laparoscopic approach. Although robotic approach has improved our technique of operating in deep pelvis, and there are still challenges like narrow pelvis in a male patient, obese patients, low and large rectal tumors where it is difficult to do a transverse stapling. And this has led to a movement from abdominal to transanal approach for total mesorectal excision. One of the proponents of this technique, Professor Antonio Lacey, recently published a report of 186 patients with mid and low rectal cancers with some excellent results in terms of quality of mesorectal resection, and it was complete in more than 95% of patients. And in terms of resection margins, both the circumferential and distal resection margins were quite acceptable. The authors regarded TATME as a safe method from an oncological point of view. However, the role of this technique is not settled. A recent report from Norway has reported an unexpected pattern of local recurrence, which they have possibly linked to CO2 emboli. There are counter arguments in favor of TATME, and currently, in my opinion, this technique should be explored and offered in tertiary centers with expertise and infrastructure, or preferably in a trial setting. If we compare the available techniques for RRR, in my opinion, we can possibly draw the following conclusions. When we compare clinical outcomes, laparoscopic, robotic, and TATME scores over the open technique due to MIS benefits. But in terms of oncological outcomes, open radical resection is still the gold standard to which all the current and, in my belief, all future techniques will be compared to. Robotic technique has shown some promise in improved functional outcomes, but the evidence is still in favor of open radical rectal resection if we take everything into consideration. Whatever the approach, but whenever and wherever possible, the surgical principles of radical rectal resection should remain the same, which include high ligation of inferior mesenteric artery, splenic flexure mobilization, high ligation of inferior mesenteric vein, wholly plane dissection with division of the anococcygeal raphe. And as surgeon, we should always strive for the quality of surgery as described by pathologist Philip Kerr. We must always remember that radical rectal resection is an oncological and not a cosmetic surgery. So whatever is good in our hands, I believe we should practice that. When it comes to the role of extended surgery in rectal cancer, the role of lateral lymph node dissection has triggered a significant interest on the approach, recurrence, and survival in rectal cancer. Lymph nodes draining the rectum below the peritoneal reflection follow two pathways. The group 1, which follows along the superior rectal and the inferior mesenteric arteries into the para-aortic nodes, and these nodes are resected as a part of total mesorectal excision. But lymphatics along the middle rectal and the inferior rectal arteries drain into the obturator, internal iliac, and the external iliac nodes, and these are called the lateral pelvic nodes. And there is a significant interest on how we should deal with these nodes. Currently, there is a Western and a Japanese view on the role of lateral lymph node dissection. According to the Western concept, only the internal iliac nodes are regional, and the remaining, including the common iliac, external iliac, and the obturator nodes, are considered to be a metastatic disease. On the other hand, according to the Japanese view, all these nodes, the lateral pelvic nodes, are considered to be regional nodes. There are differences in terms of management when there is a lateral disease in rectal cancer. In West, it's mainly managed with neoadjuvant chemoradiation with radiotherapy boost to the involved nodes, and there is a role of selective lateral lymph node dissection in unresponsive nodes to radiotherapy. In Japan, prophylactic lateral lymph node dissection had been very popular. There is a movement to the role of therapeutic only lateral lymph node dissection in patients with positive nodes on imaging. And with the introduction of neoadjuvant chemoradiation in some Japanese centers, they are also looking into the role of selective lateral lymph node dissection in unresponsive disease. As surgeons, we still see multivisceral rectal cancer, whether primary or recurrent. These tumors require extensive exenterations and preferably should be managed in specialist centers with the expertise and infrastructure. Our progress in perioperative care, blood-saving techniques, and intensive care have improved morbidity and mortality in many of these patients. We do see long-term survivors after extensive rectal cancer surgery. The next development in the surgical management of rectal cancer is the role of local excision in early rectal cancer. Currently, two strategies are under investigation. The first is the role of upfront local excision, which may be followed with further treatment with chemoradiation. And the second strategy is to offer some sort of neoadjuvant chemoradiation that leads to what is called a regress rectal cancer, and then explore the possibility of local excision. An important challenge in this approach is the identification of early rectal cancer, and current consensus, if by any standards, defines early rectal cancer as clinical T1, N0, low grade, no vascular invasion, no lymphovascular invasion, less than 3 centimeters in size, preferably, and no budding. All other T1 and T2 tumors are high risk for lymph node involvement and are high risk for local recurrence as well. The question that follows after local excision is whether it is sufficient for oncological cure. A recent meta-analysis has shown that local excision alone is not sufficient in the majority of patients. If you compare the risk of local recurrence in patients with low risk T1, it's about 7%, and it doubles to about 14%, and it doubles to about 30% in patients with T2 cancers after local excision. With these results, it's expected that the rates of organ preservation will be low. There is a need that if local excision with or without adjuvant treatment cannot preserve the rectum, can we do something before local excision which can regress it and allow better oncological and functional outcomes? Now, BRCA2 study is a very well-designed study to investigate this approach. In this study, all patients with T2, T3, and node NX patients received chemoradiation, and depending on the response, further treatment was decided. When this approach was used, there was no difference between the local excision and the TME group in terms of local recurrence at 3 and 5 years. However, the problem was that patients who required a completion TME after local excision had twice the morbidity and side effects than in patients who went for a primary TME. So this should be taken into consideration when offering patients this approach of management. One of the important problems of offering novel therapies to patients is how can we recruit patients in these studies. This is a slide borrowed from a presentation in European Society of Coloproctology meeting recently held in Dublin, where it's called the Star Trek study, where a unique approach of randomization of patients has been used. Patients with suitable rectal cancers are allowed to decide whether they want to go for a standard TME or organ preservation approach. And if the patient prefer an organ preservation approach, then they are randomized into different neoadjuvant strategies and the further approach. And the results of this study are eagerly awaited. So in my opinion, local excision is a good choice for T1 tumors with favorable histology, not sufficient for high-risk T1 and T2 tumors. There are many caveats which still need to be answered. Follow-up is intensive and not standardized, and management strategies still need to be explored. The other or the path or the option currently being investigated is what is called the non-operative management of rectal cancer, or watch and wait strategy. Current potent and I would say novel neoadjuvant treatment strategies have increased the clinical and the pathological complete response rates, and these patients have excellent survival rates, and so this has led to the study of wait and watch and wait strategy for selected patients who experience a complete clinical response after neoadjuvant treatment. One of the most important challenges in this approach is the assessment of response after chemoradiation, and this is one of the schema proposed by Memorial Sloan Kettering Institute, which propagates the use of endoscopy, digital rectal examination, and MRI, and categorizes the response into complete, near complete, and incomplete response. And based on this, further treatment is offered to the patients. These are some of the major studies on watch and wait strategy, and starting from Habergama's report in 2004, results are variable as most of these studies are retrospective series. However, the OPERA trial, which is one of the significant trials in US on this approach, the results are eagerly awaited as it is a prospective trial using what is called total neoadjuvant therapy before offering local excision to the patient. Again, my insights on this approach, it's a promising treatment strategy which can be included in a discussion with the patient, but there are multiple caveats which have to be answered before this approach can be offered to our patients. The future of rectal cancer surgery is bright, but in my opinion, radical rectal resection will still be offered to the most. extended surgery for the selected patients, and local or minimal surgery for some, and no surgery may have a role in future, which I'm not sure at this point of time. Whatever the treatment, we should strive for a high quality. Things like robotics, virtual reality, genomics, and artificial intelligence will help in improvement of rectal cancer care. But my dream of rectal cancer surgery is like a Mac burger. No matter where you are, whether in Europe, Asia, Singapore, or even Sri Lanka, the taste is more or less the same. Let's all hope that a similar standard of rectal cancer surgery can be offered to all patients wherever they are. I thank you for a patient listening and hope to meet you all in person in future meetings. Thank you very much.
Thank you, Professor Surendra Kumar. Did conclude this session.
And we invite you for tea, and there will be a SARC surgical symposium happening after tea. It's going to be very interesting. So we started sharp at 4 o'clock.